So if I could ask Jack and Joe to come up to the front, and then I will okay, everybody. All right. So if someone has a question, would you just raise your hand? A question or a comment? Question or a comment?
Pete, can I ask a question?
Please, please.
Arturo, I wonder if one of the correlates of what you're talking about is that our ability to sequence people's genome is going to lead us to be able to understand why some people are more predisposed to certain presentations and outcomes. Whether or not we can change that outcome is another question.
I agree with you. I mean, I think there are going to be some situations by which knowing that one has a deficiency, you know, if you have a defective toll receptor molecule, that is going to be informative. But I remind everyone that there is a tremendous hype with genomics, and that we have yet to see this translated into better therapy and better drugs. The first molecular disease, sickle therapy, is extremely well understood. We don't have any drugs that prevent the disease. Now, there may be reasons for that, but I think that's a cautionary tale. I think that that we need to remember also that the final phenotype is the result of the environment and the history that does so.
Okay, Richard. Go ahead.
One of the problems.
Oh, and speak. Identify yourself. Go ahead.
One of the problems that clinicians face, and this is primarily to Joe, is that although fungal disease is not uncommon, it's not common necessarily, depends on the host, et cetera. But when you parse things out like you're talking about, where the taxonomists change the names, and instead of having Aspergillus fumigatus flavus, whatever, you now have Aspergillus with 50 subspecies, et cetera, then one of the problems and the challenges has been for someone like me taking care of patients at the bedside is to determine statistically from clinical trials, et cetera, how you take care of somebody. So if you keep parsing the organisms out where there's more and more and more, you have limited resources in terms of how you design a clinical trial. How do you see that being done where you can get enough information to be able to discriminate how to treat each one of those organisms?
I think it's a point well taken of whether or not you can do this practically, and also whether or not there's going to be any kind of benefit to the patient. I think Cryptococcus might be one example where I would envision 5 to 10 years from now, the guidelines for treating neoformans versus Gaudiae might change a bit. And I think there's already some inclination that that should be the case. But whether or not we need to think about Candida parapsilosis, orthopsilosis, metapsilosis as being different from a clinical perspective, I don't think that's clear yet.
I'd like to add to that about our problem with cocci, and I'd address this question to David Stevens or G.R. Thompson, but because our laboratories in our area are not able to distinguish between Posidoceae and Imidus, they just call it Coccidioides species, because the distinction seems to be beyond the reach of the average laboratory, which is just pursuing the question that was just asked.
What I would add to that, though, is that to me, there is a fundamental biological question that has not been answered because we don't have sufficient data, and that is, are microbial species boundaries fuzzy? And I think they probably are going to be.
Are they? I'm sorry. Are they boundaries?
Are they fuzzy?
Oh.
You know, like for example, I mean, our species boundary at our level are pretty clear. You know, I mean, you cannot cross one species with the other. But once you begin sequencing and you begin to look at this, you basically got hills and valleys. And again, the question is going to be, as was asked, where are you going to set the line? Is it, and is that line going to be moved by the next set of investigators? And I don't know. I don't know, Joe. What do you think?
I think in bacterial species, because there's so much horizontal gene transfer, the boundaries really are very, very fuzzy. But I think in fungi, they're clear. And for example, in Cryptococcus serotype A and D, These are clearly different species. And then you can find hybrids, the 80 hybrids between them. But just because you can find hybrids doesn't mean that they aren't distinct species. The good example in mammals is lions and tigers. We all accept that lions and tigers are different species, but you can make a hybrid between them, the liger, and that is even further evidence that it's a species boundary.
I mean, I guess I would say that if you pulled out a cryptococcal isolate and you sequenced it, and it was very clear that it contained elements of A and D, of the old A and D, that's a hybrid, but that could have happened millions of years ago.
Right.
And in a way, this could now be, through asexual reproduction, be part of your fuzzy boundary.
So there are many hybrids at the species boundaries between fungi, but we don't accept those as their own species. They're hybrids between two well-defined species, even if they're ancient hybrids. So some of the 80 hybrids may be 1 million years old, but we don't recognize that as a species. It's at the boundary between the two species. Maybe it'll become a species, but it isn't recognized as one now.
Let me ask a question while audience is gathering up the courage to ask their own questions. For those of us who aren't geneticists, and so Joe, this is really to you, but any of you can answer. You mentioned two things that I was wondering about. Number one, you talked, unless I misunderstood you, the expansion of the genome of blastomyces, and then you used as the example, the determination of a new, or the identification of this new species, Gilchristii, which presumably was named after Gilchrist, who first discovered blasto. So what's the driving force? Is this just a natural phenomena, or is this pressure? What is it that's causing these sort of changes to occur? Has Gilchrist been there all along and we've simply missed it, and we just haven't had the wherewithal to identify it? Or the same question can be asked of the cryptococci. What is driving this in terms of the development of new species? Or are these really new species? And is this just something that's an ever progression of microbes?
So these are ancient species,
Okay.
on the order of 5 or 10 million years old. So they didn't just arise. And morphologically, they look similar in many cases. And so the original definition of these as species was in many cases morphological and biochemical and host range. The molecular analysis is what's driving recognition that they are distinct genetic entities.
Okay.
And so the question then really is, what does that mean?
Yep.
If they look the same, shouldn't they be the same species? But unless they're exchanging genetic material in the wild, they're different species.
Yeah, sure. I mean, and one can see the relevance of this if you start applying it to the human host, and you see, as an example, a person with blastomyces, both normal hosts, one that does very well and just has an uncomplicated course, and then one that has a very complicated course leading to death. And you always ask the question, why? Was it their host susceptibility, or was it something about this quote-unquote strain that was more virulent? And I think that clearly we don't have enough of that kind of information. Tom, you had your hand up.
Joe, in working with Siebel de Hoog and the committee on the Isham nomenclature challenges, what becomes apparent is how to strike the balance of allowing the progression, the important and inevitable progression of good science and leading to an improved understanding of molecular taxonomy, versus from the clinical micro standpoint, which every clinician can identify with, is nomenclatural stability. And I draw the analogy to just a very quick list where we look at everything from Penicillium mornifii now to Telleromyces, where we find a patient with Cladophilophora bantiana and say, well, it used to be Xylohypha bantiana, it was Cladosporium bantianum, Neoscidolydium, a foot lesion we recently had goes back within 6 years, 4 different nomenclatural changes. June has now come out with her concerns about crypto, and immediately there's the response that says, oh, well, you can't stop science. No, nobody wants to stop science. But what becomes apparent, becomes a very critical problem, is that name carries powerful implications for everything from prognosis to treatment to clinical manifestations to molecular, to the potential environmental microbiology. And we immediately start thinking in those terms. And if it starts to change that rapidly, we start to lose that. So, yet that is expected often to be used in the clin micro lab. So the question then arises, well, like any other clinical tool, should there be some validation before it's adapted by clin micro? So if we have a new assay for an MIC, we have CLSI, if we have a new tool for measuring hematocrit, we have to go through a certain measure of validation and standardization. But as soon as a new nomenclature comes up from one laboratory, immediately it's just said, well, the name has changed. And then micro labs are seeming almost to adapt to it. And with no validation, and yet you pick it up, you pick up the next piece of literature and you say, well, another lab has changed. So we can see that the science has to progress, but at the same time, what are your thoughts in terms of at least saying, for clin micro, there needs to be stability, if anything, for quality of patient care until there's validation, until there's standardization of a given name?
I think there's room for both views. And so in a clinical microbiology lab, it's probably good enough to know if it's a Cryptococcus isolate. And maybe there's some further benefit to know if it's a Neoformans or a Gaudii isolate. But do you really need to know which of the 5 sibling species within Gaudii it is? From an epidemiological perspective, it's probably important because you want to know if it's an expansion of the Vancouver Island outbreak, and that's one specific lineage within the 5 sibling species. But I think both of these views of the universe are not incompatible with each other. There's no question that these are species, and that taxonomists and people interested in fungal phylogeny are going to name them. And then how we think about that from a clinical perspective or a clinical microbiology perspective to simplify things to the level of detail we need to know to effectively treat patients, I think that's where we really need mycologists to help make sense of that. But just saying it's going to be complicated to give them names, I don't think that's going to be persuasive to the taxonomists. They've been recognized as valid species, they've been named, and people who work on it from that perspective will continue to use some of those names. And I think there are cases, like within the Sporothrix species complex, where some of those distinctions really probably are important.
It's not to say that we recognize the importance of the evolution. It's the difference when a given laboratory says, this is the name change. Right? And then another laboratory says, no, this will be the name change. And then this is what creates the confusion, so that within a short period of time, you may see an organism change from, in a short period of time, 4 or 5 years, several times over.
I agree with that. I think you
And
should
that's
seek
what we're
consensus.
requesting from the ISHM committee, of a kind of standard of, or at least some spirit of nomenclatural stability from the clin micro lab, not to stop the science, but the idea that there needs to be clarity in communication, and one accepting just one laboratory's opinion of a given nomenclature may not be stable at that point. Your
Right.
thoughts?
I think if a name is not accepted by the community, it's not a good name. So you do need to seek consensus if you're going to name something, and then it needs to have some value to it.
Other, Shmuel?
Shmuel Shohan from Johns Hopkins. I have a statement and then a question. So the statement is, although I agree that immune stimulation or immune modulation is important, I will speak for the antifungal side of things in that I think it's done quite a bit, in that we used to see patients dying of aspergillus left and right, and now it seems like they're dying of their leukemia, and sometimes dying of aspergillus as well. And I also think there's a lot of variability in how people give antifungals, and that perhaps we're not getting the most out of our agents, and work in that area hopefully will improve things. And then the question regarding immunotherapy, what kind of studies need to be done in order to understand the immune situation both in the tissue and globally, so that we can perhaps immune modulate?
Arturo?
No, I think your point is very well taken. I mean, we definitely do better today in preventing a lot of these diseases. Often is if you use prophylaxis than it used to be. But I would argue that for many of the invasive mycoses, the ones that the mortality and morbidity hasn't really changed very much. For cryptococcosis, in particular in the immunocompetent, I mean, the work that Jack did and the numbers that he did in the 1960s pretty much applies today. You know, I mean, that hasn't changed. And, you know, he reported back then that 1/3 died, 1/3 got cured, and 1/3 went into remission, and then the other third then relapsed. And obviously, that was a time in which they didn't have fluconazole, they didn't have a lot of these things. Now we put these people often on it. My sense is that there are two problems. One of them is that the tools that we have for immunotherapy are relatively, are not specific. They're not at the level of a PD-1 inhibitor, for example, that can be used in this situation. The second point is that we often don't understand the degree to which that inflammation is helping us or hurting us. And what I believe in time that physicians will be able to tell. And once you know that, then you will know how to use it. I mean, right now we modulate inflammation either by throwing things like steroids on it, or perhaps, whereas we focus primarily in reducing it by reducing microbial burden.
Okay. I think we have time for, it's getting to be 9:30, so I want to limit it to another couple of questions. This gentleman in front, and then, well, go ahead. Neil, if you had.
Yeah, it's Neil Clance, University of Pittsburgh. So I had two questions really for Arturo, and one was a therapeutic question, one was a diagnostic question. So antimicrobial resistance is a major challenge, and the emergence of CREs, these are bugs that live in the gut. Candida resistance is a problem, it lives in the gut. There's overlap in populations that are at risk for both these types of resistance. Do you see in the near immediate term that something like fecal transplant would be a viable strategy for high-risk patients, say transplant recipients, as an anti-resistance strategy?
I don't know. I mean, it certainly hasn't been done, but it works remarkably well with C. diff. You would think that perhaps if you could transfer flora, you could inhibit it. I can imagine in some areas, like for example, the Candida vaginitis, where there is a lot of data that you get it when you disrupt the environment, that in that case, so you basically did a series of calculations, total empiricism, whereas you didn't do that in oncology. In oncology, you made a diagnosis because the therapeutic margin was so narrow. What you're now saying is that with the increase in resistance, and as we lose some of these antibiotics and we have to rely on the more toxic antibiotics, that our margin is becoming smaller. And I would like to think that that's going to push us more towards a world of making a diagnosis. And I hope so, although I understand what you're saying, that there's also the pull to basically play the numbers. And I'm sure Jack will add to this.
No comment.
You have no comment.
Yeah. I would argue that one of the challenges to both of these realities, the emergence of new species and the need to identify an organism, et cetera, is going to be challenged by our continued reliance, or greater reliance on non-culture-based serologics. It's not going to allow us the type of specificity that we currently have with our culture technology.
I hope everyone in the room knows that azoles are used in agriculture.
Yes, I think we do.
Yeah, I hope.
And veterinary medicine.
Yeah. Okay, I think we have time, one more question, and then we'll wrap it up tonight. Go ahead.
Thank you. I'm Tobias Hall from MSK. I just wanted to say one thing quickly to the prior questioner, and that is that we are actually conducting this kind of work in a clinical trial at our institution where patients are getting autologous fecal transplants during the engraftment period, depending on whether they've lost bacterial diversity, because that is something that correlates with transplant survival. And we also are understanding from the work from Andrew Coe and others that there's clearly bacterial fungal interactions in the intestine that are important for colonization resistance. But the question I wanted to ask to the panel was really this notion of immunotherapy, because many of us think about this a lot, think about fungal immunology quite a bit. And I would say that immunotherapy so far has been most successful in cases when there's a known defect. For example, if someone has a mutation, for example, in CARD9, that leads to CNS fungal meningitis, which could be ameliorated by GM-CSF, which is in part controlled by that gene. But for the many patients who don't have these defined Mendelian defects that lead to fungal disease, I think one of the big issues is that we don't know enough about fungal immunology at the tissue level. That has been very difficult to achieve in human specimens. And we also don't have a good correlate of immunity in a sense that we don't know what the immunologic markers are that we should strive for in patients. What do we measure immunologically that's relevant, if we're going to intervene? And I think that, to me, that's a real big black box that we need to focus on, I think, in the near future. And so I'd love to hear your thoughts.
What I would add is that there is certainly one type of immunotherapy for which works very well in immunocompetent individuals, and that's passive antibody therapy. It is well tested. We had 40, 50 years of experience before it was abandoned in the early 40s. I think that the reason that some of the other ones, we can talk about this all night, but I do think that as a field, the field of infectious disease, basically with the advent of antibiotics, abandoned modulating the host. At the beginning of the 20th century, between the 1890s and 1940, your therapy was based on helping the host. You provided antibody therapy, you made them hotter, you did all kinds of things. And then we now try to kill the microbe. And the problem is that killing the microbe doesn't reduce damage in all cases. And that's the wall that we're getting into.
I think with that, we're going to wrap up the evening. I want to thank our speakers for really giving us a great kickoff.